Okay, so before we begin, for people who aren't aware of Dr. Harris, I don't know if you've been under a rock, but he's definitely one of the UK's leading practitioners in the field of medical aesthetics. He's actually a big advocate and lecturer that speaks regularly about body dysmorphic disorders. You've also recently had a publication about alienization, which is just kind of the unnatural look, this snatched look, this very unnatural, over dramatic look in medical aesthetics, and how you're a big advocate on keeping things very natural. And at the same time, you've treated over 40,000 faces over your career, which is very impressive. And I'm very happy that and honored that you took the time to join us here in the chat today. Thanks so much.
Thanks for inviting me, Dan.
I would like to know more about this dissolving clinic.
I call it the dissolving clinic. Actually, I call it the normalization clinic more because it also involves new treatment. So dissolving and new treatment. It's part of my regular clinic, and but I gave it a name just to make people aware of it and to, just help those who need it really. But I spend a lot of my time dissolving, and you do too, don't you?
Yeah, we do a lot of dissolving here, and we get a lot of questions about it. And it's nice that we have open conversations, because there's a lot of, on one of my YouTube videos, I did post about sometimes the rare complications if you have to flood a face, or if you have to flood an area with hyaluronidase. And that sparked some type of trigger where people thought that, hyaluronidase is dangerous. It's not dangerous. It's just there's a very small percentage of people usually who are a little bit more mature and have had a lot of filler, have expanded a lot of their tissues over the years. And then once you dissolve that, then it's kind of like a balloon, which is just deflated. In most cases, it works very well, and I rarely have any issues with it. But I just, letting people know that it's not 100% foolproof. And I would like to know your opinion on that.
Yeah, no, I agree. And we have to understand that fillers in themselves are not inert. As you say, the kind of problems we see are from overfilling, and the fillers most likely, rather than the hyaluronidase, which is an enzyme and substrate specific by definition. And so it does not dissolve your own tissue. It's specific to hyaluronic acid. And as we know, there is a regular turnover of hyaluronic acid in the body, so that your entire stores of hyaluronic are turned over every few days. So it's replenished. We sometimes see the effects of dehydration or some discoloration from hyaluronidase, but largely it is safe.
I would like to talk more about your discussions and your lectures about body dysmorphic disorder, body dysmorphia. Do you have any tips for providers who are clearly dealing with the client who comes in with body dysmorphia with regards to medical aesthetics? They can't see that they're overfilled and they want more, or they're pushing for something. And how is your approach? How do you approach that?
Yeah, it's a really difficult one, because as a general rule, I think it's a very bad idea to treat someone with suspected body dysmorphic disorder, because clearly this is a psychological disorder rather than an actual physical thing going on, and they really need psychological intervention rather than being filled with fillers, which they end up being very dissatisfied with anyway, and can cause a deterioration in their mental state. And we have to be very careful with these patients, because they have a very, very high suicide rate and significant comorbidity with severe depression and other disorders. So I think it's very important to, if you suspect someone with body dysmorphic disorder, to really try and, shall we say, psychoeducate them in terms of what's going on. And what you can do is ask them to rate the severity of what they perceive as the problem, and then provide your own rating to see the discrepancy. And that could be an opening way to discuss the issue with them. And I think then really what one should do is not just sort of let them go, but bring them back for a follow-up appointment, when you would discuss maybe referring them for psychological help. And the things that work quite well with body dysmorphic disorder are cognitive behavior therapy in combination with SSRI type antidepressant medication, and they seem to do reasonably well on that. But certainly aesthetic treatment is not the solution, and you're going to run into a lot of problems if you go down that route, because they, as I said, can become very dissatisfied and and want to take you to court, etc., etc. Can be a very, very difficult situation for both.
Yeah, it's difficult to pick up because there's a lot of people who are just have an attentive eye, and they look well, they look great, but you're always wondering, is this a body dysmorphic disorder? Because I'm having a hard time seeing what they see, and they look perfect, and they're worried, very worried about my new details.
Yeah, I think that's a clue. But I think you need to establish how much this interferes with their day-to-day living, and prevents them from doing things, going to work, social interaction, that kind of thing, and how much time they spend preoccupied with, with their perceived defect. So there are certain questions you can ask to sort of, get.
So do you do body dysmorphic disorder kind of like a screening tool? If you feel that potentially a client comes in, is there like a checklist, like a questionnaire that you'd have them ask, or you'd ask them?
I do have the screening BDD from the National Institute for Clinical Excellence. They set guidelines in the UK. So it says, do you care a lot about your appearance, and what specific concerns do you have about your appearance on a typical day? How many hours do you spend thinking about it? So as we said, so more than 1 hour a day preoccupied with your perceived defect is considered excessive. And what effect does your appearance have on your life, and does it interfere with everyday tasks? So pretty much, and socializing. So pretty much what we said. Yeah.
Excellent. Well, I can't wait to implement that, because I'm definitely going to implement something as an adjunct, and I was thinking about bringing something in like that, and I'm happy that that you addressed that. I'm definitely going to take that up. I don't know if you've changed the name, but it was the non-surgical lip lift. Now I think it's non-surgical lip tubercle.
Yeah.
I would love to chat about that.
Yeah, so non-surgical lip tubercle, the non-surgical tubercle, lip tubercle lip, NLT, is, I think, a more accurate way of describing my procedure, because it specifically deals with tubercles. And the reason I changed it from NLL, which is the non-surgical lip lift, is because really fillers don't really lift to any significant extent. And so, although there may be the impression of lift, they don't really lift. And I thought that was a bit confusing, and so I changed it to NLT, which is the non-surgical lip tubercle. Everyone was just injecting the borders, and a lot of people still do that. But I was encountering problems with that in terms of filler migration. And I think that just as I got to looking at it more closely and really understanding the anatomy of the lips, I think I moved away from that, and in particular embryology. And so I developed this technique as a result of all that. That is to say, working with the natural lip anatomy to enhance it by really understanding embryology and the way the lips are built, in particular relating to tubercles, which I consider the building blocks of the structural building blocks of the lips. And I think the kind of way that the tubercles present are very individual, and I also did a classification based on that, and we're looking at that now. We're doing a very large study looking at this embryological classification, which really helps differentiate different lip types. And the problem with injecting the border, and in particular, I'm quite outspoken against tenting, because what tenting does is reduces all lip types to a single lip type, so making everyone look the same. And I've noticed now they're trying to change it by introducing horizontal injections to bring out the tubercles. They've realized it's not just about vertical height, but rather it also involves the lip tubercles themselves, and we can't continue to ignore them, because this is what differentiates us as individuals.
actually, you are one of the main providers of why I actually really started pushing for my Clarius. I purchased the Clarius.
Oh, good.
And I was using it. Yeah, I purchased about 6 months ago, and then after that, I think I sent you a message maybe a couple months in asking you what you thought. I wasn't using it all the time because I thought it just took a little extra time. And you mentioned just practice, get your hands wet, and just get your feet wet and use it often, and then you'll use it more and more. And I do. I use it a lot more now, and it's actually a lot quicker because I know how to use it, right? So
exactly, and that's really great to hear. And I think it is fast becoming an essential tool. Really, where really we all need to really get into using it regularly. And as you say, it does become easier to use and takes less time to do. But it is a really major safety tool, which I think we all really need to get into for sure.
it's 8:33 p.m. in UK, 3:33 here, and that's basically it. I appreciate you taking the time. This is lovely meeting you.
No, it's really good to meet you too. Thanks, Dan. I appreciate that.